voice, the Cleveland Clinic's Rupert B. Turnbull, outlining the coming hour's consultation on management of ulcerative diseases of the colon.
There are a number of things we ought to cover here. We'd like to dwell on ulcerative colitis and the various types, the surgical treatment, and some of the complications like the persistent, unhealed posterior wound following proctocolectomy. We'd like to dwell a bit on primary resection of diverticulitis of the sigmoid colon and to say whether this is good or bad under all circumstances. We'd like to talk about cancer and ulcerative colitis. Who gets a cancer and how long do they have to have the disease? And perhaps we might even touch on preparation of the colon for surgery.
Moderator Turnbull's panelists are drawn from various medical specialties. Alex F. Castro of Washington, D.C., a surgeon. Moses Paulson of Baltimore, a gastroenterologist. T. Wilkins Davis of Washington, D.C., a radiologist. And to begin this edition of Audio Digest Surgery, Volume 17, Number 13, the week of July 15, 1970, here again, Dr. Turnbull.
I'd like to call first on Dr. Alex Castro. Dr. Castro.
When Dr. Turnbull asked me to give a dissertation to encompass all of the inflammatory diseases of the colon, I managed to rid myself of most of the problems with the ulcerative diseases and confined myself to 3 cases. These 3 cases have been extremely baffling to me, and they show that diseases affecting the large bowel, though generally and the greater majority of the percentage will show themselves with obvious signs, and the diagnosis is fairly simple. Sometimes in people that are over the age of 50, other circumstances come in, and there may be some mimicking of one disease with the other. This, of course, would complicate the clinical picture. I've recently reviewed about 50 cases of diverticulitis that we've operated on, and over 250 cases of chronic ulcerative colitis. Most of these were not operative, though, but they are patients that we have seen. And in this group, there were these 3 patients. And these 3 patients presented themselves as inflammatory lesions of the colon, which were localized in the left colon, 2 of which were localized in short segments of the left colon, and the 3rd one was involving the entire left colon from the splenic flexure to the rectosigmoid junction. The presenting symptoms of all of these were, of course, those of partial obstruction of the left colon with passage of small, formed, bloody stools, abdominal pain, and gradual weight loss over a period of several months. Rentgenograms confirmed the presence of a constricted segment of the left colon varying in length between a few centimeters to the entire left colon. Sigmoidoscopy showed a normal mucous membrane in the rectum with some spotty inflammatory changes typical of diverticulitis in the lower sigmoid. In one case, the changes were thought to resemble a mild mucosal colitis, but after treatment with sulfaphthalidine, these changes seemed to vanish, and we neglected to pursue this diagnosis. At operation, other than the area of constriction with obvious inflammatory changes, the colon was considered normal. In other words, there was no evidence of any inflammatory disease in the rest of the colon. It was localized to the area of constriction. Resection and end-to-end anastomosis was performed with no problems. Postoperatively, during the hospital course, one patient disrupted the anastomosis about the 4th postoperative day, began to leak through a drainage site, and a proximal colostomy was established. She proceeded to develop a full-blown picture of acute ulcerative colitis with destruction of the colostomy, and in spite of a subsequent ileostomy, she died on her 22nd postoperative day. Autopsy confirmed the diagnosis of ulcerative colitis of the mucosal type. An X-ray picture of the constrictive lesion was thought to represent diverticulitis. There was a lot of discussion about it later on, and some people said that this was not diverticulitis. The specimen postoperatively shows a lot of granulomatous thickening of the bowel, but the mucous membrane looks perfectly all right. This specimen that this patient showed at postmortem had very small ulcerations, but they were eroding through into the submucosa, and she had a massive toxic reaction from this. The second case is a case that showed a little changes of what seemed to be mild mucosal ulcerative colitis on sigmoidoscopy, and the pathologist was warned that there was a possibility that this was a combination of both of these diseases, and he came back with a firm diagnosis that there was no ulcerative colitis whatsoever in that mucous membrane that we had excised. Well, The patient had an uneventful hospital course. She was discharged and seemed to get well after the segmental resection of the sigmoid for what again was called diverticulitis. Got along quite well for about a month, and then she began having bloody stools with diarrhea. And even after 4 months of continuous and thorough medical treatment, she could not avoid further surgery. An ileostomy was done with a colectomy, but the patient unfortunately died on the 6th postoperative day. Now, the third and last case was that lady that had a left colectomy with a transverse colon anastomosis to the rectum. She was followed for about 3 months postoperatively when she seemed to be perfectly all right with apparently no complications. Then she began again, like the others, showing blood on the stool and mild diarrhea. Sigmoidoscopy showed a mild mucosal colitis. Medical treatment has been successful in arresting the advancement of this disease, and barring a few days of mild symptoms, she has remained fairly well for the past 4 years. Now, this type of association with what appeared to be diverticulitis and ulcerative colitis has been described before and represents a gray zone in diseases of the colon, which very well may be frustrating to the surgeon and to the clinician, but is extremely dangerous to the patient. In retrospect, total colectomy and ileostomy would have saved the 2 patients that died if it had been done at the time of the first surgery. Unfortunately, at that time, we were not cognizant of what we were dealing with. I'm presenting these cases to make us all aware that in cases of an elderly patient, not only do we treat perhaps one disease, but several other diseases may be rearing their heads and complicate the picture of either diverticulitis, ulcerative colitis, and whatnot. We also must consider the changes that occur from vascular irregularities in the patients, particularly in some of the patients that have abdominal aneurysms with some disruption to the blood supply of the left colon.
Crohn's disease of the colon, or granulomatous colitis, certainly does masquerade as diverticulitis because they are both perforating diseases, and all hell breaks loose after a resection, as Dr. Castro has demonstrated to us. The pathologists don't help us too much yet. I think it's the clinicians and the surgeons that have to tell them it might be one of these diseases, and then perhaps they'll find it a little bit better. They're no different than we are in this respect. Dr. Paulson will talk to us now about ulcerative colitis. Dr. Paulson.
As a gastroenterologist, I'd like to bring to your attention a problem that concerns not only our group, but certainly the general surgeon. The factors involving susceptibility to malignant disease in ulcerative colitis eventuating in the question of prophylactic panproctocolectomy. Now, there's certain generalizations that certainly can be made with regard to the incidence of malignancy in ulcerative colitis. I think it's generally agreed that about 4 to 6 or 7% of those with ulcerative colitis will eventually manifest malignancy. And we can translate that in 2 other ways, that the extent of malignancy in ulcerative colitis is about 5 to 10% greater than that which is ordinarily found in those without ulcerative colitis in the general hospital population. And also, again, we can roughly say that malignancy in ulcerative colitis appears about 30 times more frequently than that of colonic malignancy in the general population. Now, there are 4 factors that concern us with regard to susceptibility of malignancy in ulcerative colitis. The first is that of age. Obviously, the earlier the onset, the greater the likelihood of carcinoma. So that Michener pointed out as far back as 1961 in his classic article, in more than 400 children who were studied with this disease, whose first attack occurred before 15 years of age, within 15 years, 12% of them had developed carcinoma of the colon and 10% had already died. It's also known that those with universal colitis or total colitis or colitis involving the entire colon by means of the Roentgen rays, if in those individuals such a situation is noted before 25 years of age, that these people have twice the chance of developing malignancy than those who develop an ulcerative colitis involving the entire colon after 25 years of age. The second thing of prime importance in helping us determine the susceptibility of malignancy in ulcerative colitis, and there a competent radiologist primarily interested in diseases of the digestive tract is extremely helpful. This concerns the longitudinal extent of the disease. Those who have ulcerative colitis and are essentially normal radiological picture are the least at risk with regard to malignancy. And on the other side, those that have total involvement are obviously most at risk. Those that manifest left-sided colitis assume a slightly increased risk. And it's interesting that those cases where the disease is restricted to the rectum and to the sigmoid, the risk is not too much greater than that of the general population in the development of malignancy. Thirdly, the duration of the disease is the most important element. Those that have the disease for a period prior to 10 years will develop carcinoma hardly in excess of 5%. But in the next decade, the incidence rises to almost 25%. And then following that, the rate may rise even as rapidly as 6% per annum. However, the duration of the disease in relation to susceptibility to malignancy has to be tempered by the degrees of severity. Now, those cases who have the disease for long periods of time with marked severity and who show very little respite from the active process are those most likely to develop malignancy eventually. We rarely see it in a case who's been fortunate enough to have just one attack of the disease. Actually, there are no more than 3 to 4% of people developing ulcerative colitis who are fortunate enough to just have one attack. And in those individuals, rarely has malignancy been encountered. And finally, in those that are asymptomatic for very long periods of time, statistically, certainly very few will manifest malignancy. Early diagnosis of malignancy, colonic malignancy and ulcerative colitis, is a thing to write about and to talk about, but which we rarely ever accomplish. Exfoliative cytology, as far as colonic disease is concerned, is certainly not as helpful as it is in gastric diseases or in diseases of the uterine cervix. Actually, there are no distinctive symptoms, and we don't make the diagnosis early because at least 50% of the cases of ulcerative colitis develop the malignancies above the rectum and the lower sigmoid. The brunt of the involvement is usually in the rectum and the lower sigmoid. This atypical distribution is characteristic of this disease, and the radiologist will be the first to tell you that it's extremely difficult for him to diagnose malignancy rather early in ulcerative colitis because its appearance is entirely at variance with the picture of carcinoma as he usually encounters it in the large bowel among individuals who've never had the disease. Besides the malignancy itself, 50% of the malignancies are of high grade in ulcerative colitis, and in those without the disease, the literature talks about only 20% manifesting high-grade malignancies and so on. So then, in view of all of this, the question arises, and you've read this, I'm sure, from time to time, as I do, that after 5 years, and certainly after 10, with ulcerative colitis, the colon, including the rectum, in its entirety, should be extirpated as a prophylactic measure. Now, there are 3 reasons in favor of panproctocolectomy as a measure for the prevention of colonic and rectal malignancy. One is that ulcerative colitis of more than 5, possibly 10 or longer years duration is a precancerous lesion. Secondly, the compromise operation of an ileoproctostomy so as to avoid the carrying of an abdominal anus in terms of a permanent ileostomy, that doesn't take care of the rectal and anal situation because the disease goes on merrily there despite an ileoproctostomy, and these segments may eventually be seats of cancer. So that since proctocolectomy is compatible with well-being, and for the other 2 reasons just enumerated, this operation ought to be done. Now, what are the objections? The objections are that as a prophylactic measure, the procedure will be employed in a majority who would never have developed colonic malignancy regardless of the severity or the duration of the disease. And besides, we have no definition of the colonic patient most at risk for malignant change in sufficiently precise terms to be applicable to the individual patient. So further tests are needed which will indicate that individual patient as being in a precancerous state. And besides, and I think this must be made plain to patients in fairness who are urged to have an ileostomy performed as a prophylactic measure with respect to malignancy, that this does not prevent them from developing malignancy elsewhere in the body upon the eradication of the colon. Now, we understand that among one another here, but that's rarely told to patients. I have seen total gastrectomies for gastric carcinoma removed, only to have the patient develop 6 and 7 and 8 years later a mammary malignancy or a colonic malignancy, totally unrelated to the original process. But the most important point, I think, against the use of pan-proctocolectomy as a prophylactic measure, now I'm emphasizing prophylaxis here, as a prophylactic measure is the following. Nefsker and Atchison, two English biostatisticians, studied 1,700 cases among the United States military personnel who had the diagnosis of ulcerative colitis made while in the armed forces. A 17-year follow-up indicated that in those cases manifesting a total colitis, as indicated by the Roentgen rays, 13.2% died at the end of 17 years, whereas 7.4% died of situations associated with ulcerative colitis, but not concerning malignancy. The total then is 20.6% deaths at the end of 17 years with total or universal ulcerative colitis. Now, until we can show that a comparative series of total ulcerative colitis in whom pan-proctocolectomies have been done for ulcerative colitis have a mortality rate substantially less than 20% over a 17-year period, then I think we need to be guarded in many instances in recommending pan-proctocolectomy as a prophylactic measure for the relief of malignancy and ulcerative colitis.
Dr. Paulson, you've given us much to think about. You didn't come right out and say so, but we all recognize two types of nonspecific ulcerative colitis, one of which is definitely a pre-malignant disease, and you hinted at it broadly by saying that the entire colon was involved, while in the segmental forms, which is transmural Crohn's disease, there's a very little incidence of cancer, perhaps not greater than in the general population. And to have a gastroenterologist suggest prophylactic proctocolectomy is a new experience for me. When we, and all of us, we surgeons, whenever we suggest that a patient should have a prophylactic proctocolectomy, I rather think they don't look upon us with approval. And I'm sure the entire audience congratulates you on your attitude. It's very rare one encounters granulomatous disease of the colon in childhood.
Major distinction, ulcerative colitis in infancy and childhood from that of adults, that obviously they get the disease much earlier. They often get it much more severely, and because they get it much earlier, from the statistics that are available to us, they're more likely to develop cancer at a relatively young age in life. But save for that, I don't make out any major distinctions in the two processes. These kids get toxic colons, they get the complications that we're familiar with, they get the perforations, and of course, every now and then, they've got to have pan-proctocolectomies too.
Our experience, if I might add it here, who has not reached puberty almost always has mucosal ulcerative colitis. And this is a pre-malignant disease, and hence the high incidence of cancer Dr. Michener reported. Dr. Castro, could you comment on that? Does that go along with your thinking?
I think that goes along with what we've observed. We haven't seen too many children. We perhaps have somewhere in the line of 25 or 6, I don't have the statistics on hand, children that we have been consulted surgically about. And it is my recollection that most of these kids had the mucosal type rather than the granulomatous type of disease.
Next, Dr. Davis, a radiologist, will tell us how to tell the difference radiologically between mucosal ulcerative colitis and transmural Crohn's disease of the colon, sometimes called granulomatous colitis. Dr. Davis.
What part of this total responsibility of ulcerative diseases of the colon does the radiologist shoulder? I think there's a large part, and rightfully so. First of all, we play an important role in making the initial diagnosis of an ulcerative disease of the colon. Secondly, we play an important role in diagnosing the complications associated with the ulcerative diseases of the colon. Many times these complications are more life-threatening than the original disease itself. And thirdly, after the clinician has treated the patient, either by medical means or by surgery, then what is the status of the ulcerative disease process after treatment? I submit that one of the most disgusting things I've had to do is to answer this question: is this ulcerative colitis or is this granulomatous colitis of the colon? The clinician wants to know this. The gastroenterologist wants to know it because he says that his treatment modality may have some bearing on this. I submit also that at this present moment, we are not able to make a definitive differentiation between these two diseases, especially when they are of a segmental nature. We have no problem demonstrating the lesion, but there is still a significant problem in making a definitive differentiation. In the case of ulcerative colitis, a fairly early, fairly fulminating ulcerative colitis, the thing I want to point out are the character of ulcerations, particularly in the transverse colon. These are so-called collar button-like ulcerations which burrow into the submucosa, and occasionally you will find that these ulcerations will communicate with each other, giving you the so-called longitudinal forms of ulcerations. And I would think that if I had ulcerative colitis, this would be the worst thing that could happen to me, was to end up with ulcerations like these, because I think that these are probably the type will perforate more freely. Post-evacuation exposure show a coarsening of the mucosal pattern. You know that this is a disease which begins with the mucosa, and so one of the first things you may see is merely coarsening of the mucosal pattern. I'm not describing here nodularity, but merely coarsening. The pneumocolon exposure shows one thing which is significant, that this colon is distensible, which means that we do not have too much thickening of the wall. Case of ulcerative colitis, which is more advanced, we have some shortening in the right colon and possibly some shortening in the transverse colon, but feathery type of ulcerations are seen along the medial aspect of the descending colon, and pseudopolypoid formations as indicated by rounded radiolucent defects. At an advanced stage of ulcerative colitis, we have shortening of the colon, pipe stemming of the colon, and unless you had multiple exposures, you would be hard put to it to say whether these are due to localized areas of spasm or whether they're due to organic strictures. The end stage of chronic ulcerative colitis, you have shortening of the entire colon, there's pipe stemming, there's a fixity of contour, but this is one of the things that will happen in the chronic phase. The ileocecal valve becomes patulous, and so there's no problem filling the ileum, and it should be easy to get a backwash ileitis. A comparison of the radiographic features of ulcerative colitis and granulomatous colitis. With these findings, the patient most likely has ulcerative colitis, or the patient most likely has a granulomatous colitis. In the granulomatous colitis, the rectum is spared 95% of the cases, where it is not spared in ulcerative colitis except in 5% of the cases. The ileum is involved in 76% of the cases, and the characteristic lesion of the terminal ileum in these two diseases, I think is very important. Because in granulomatous colitis, you have the typical appearance of a granulomatous or regional enteritis, whereas the ileitis that's associated with an ulcerative colitis is a backwash type of ileitis, which is primarily a mucosal disease. Say, for an example, when a total colectomy is done, then the ileitis disappears and very rarely recurs. The skip areas are common in granulomatous colitis. They're not very often seen in ulcerative colitis. Internal fistula are prominent in granulomatous colitis and in series, which was taken from the Pediatrics 1968 and from the Medical Annals of North American for September 1969. They discuss mucosal involvement of granulomatous colitis being eccentric, symmetrical for ulcerative colitis, pseudodiverticular, positive for granulomatous colitis, but not for ulcerative colitis. These transverse fissures, these are deep fissures which burrow straight through the entire wall of the colon, which we do not see in ulcerative colitis. The longitudinal ulcerations are frequent in granulomatous colitis, but not so in ulcerative colitis. And you get the polypoid mucosa with large nodules and thumbprinting in granulomatous colitis, but they're scattered pseudopolypi in ulcerative colitis. Serrations, as you will see in the transverse colon, uncommon in granulomatous colitis and common in ulcerative colitis.
There are more patients with so-called granulomatous Crohn's disease of the colon for you to x-ray than there are patients with mucosal ulcerative colitis. And this is a surgeon's disease, while mucosal ulcerative colitis is a gastroenterologist's disease. However, Dr. Paulson has pointed out that perhaps he'd like to have some of those patients operated on to prevent cancer.
Our panelists pause momentarily before beginning a question and answer session, long enough for me to signal the end of Side A of your program, Doctor. Side B may be heard by just flipping over your recorder's cassette or two reels. Management of ulcerative diseases of the colon continues on Side B of Audio Digest Surgery, Volume 17, Number 13. And once again, our moderator, Dr. Rupert B. Turnbull.
Now we can start our questions. We'll start with Dr. Castro. Dr. Castro, how do you prepare the large bowel for surgery when obstruction is present and when mechanical cleansing is impossible?
Under those circumstances, I will intubate the patient, and I presume that this is a total obstruction. Under those circumstances, it is rather impossible to prepare the colon, and the patient should be submitted to a colostomy prior to any definitive surgery later on.
I think this is an admirable approach. What will a colostomy do? Will that help prepare the distal colon?
It will, yes. It will decompress, of course, the colon, get rid of all the packed up excreta in the large intestine, and in many cases, if it's a benign disease, the obstruction will let up, the edema will subside, and continuation of the lumen will be established. So much so that in cases of diverticulitis years ago, because of this recanalization, if you want to call it that, of the colon, the colostomies were closed, much to the chagrin of the patients. And this, I'm sure, we're not doing much of anymore, because they got a recurrence of the same problem they had before the establishment of the colostomy.
I think what you've said is very important. So many doctors think that the decompressing colostomy won't empty the distal colon, and they fiddle around with enemas and so forth, but actually once the obstruction is relieved, motility returns, and that colon does empty by and large. There are a few patients in whom it won't, but this is what you rely on, isn't it?
That's right. I think the ones that don't empty out are the ones that are involved with malignancy rather than benign disease. Don't you agree to that?
Yes, I think that's probably right. And Dr. Paulson, do you as a gastroenterologist take it on yourself to try to empty the colon in a patient who's obstructed before you turn them over to surgeons?
If there's good evidence to suspect an obstructive lesion, we ask our surgical colleagues to come in
Now,
and manage the situation.
Dr. Davis, don't you suppose that some of your colon x-rays complete obstruction and create an acute obstruction out of a chronic obstruction when you put barium in?
I assume that you're speaking about a regular barium enema study.
Yes, in a patient who has a partially obstructing cancer, say. Are you wary about this? Does
No,
it worry you?
I tell you, the reason I'm hesitating is this. My basic routine procedure is if I find a lesion which is stenosing and it's real tight, the only thing I will do is to inject enough barium to traverse the entire length of that lesion, and then I quit. I make no effort to fill up the colon because I've had the experience of not being able to get it back.
Just a little plug instead of a big one.
That's right. Now then, years ago, when we were using the regular USP barium, the non-micronized type, and the patients did not evacuate very cleanly, I have seen this. And so this was one of the reasons that I think I got around to just demonstrating the lesion and letting the surgeon worry about the rest of it.
If you suspect this patient is partially obstructed, might you use a liquid preparation like powdered hypake solution instead of barium?
Yes, it might be used. And we've also used gastrographing in some instances because it will cast a dense shadow too. But the one thing we don't do is that is send the barium down in the form of a barium meal. This would really be creating havoc.
Well, this is an old familiar ground to everyone in this room. We hesitate to even have a barium enema if we think a patient has colonic obstruction, Dr. Davis, or we might ask for a hypake solution or some such. Now we can get on diverticulitis. Dr. Paulson, a man of 75 brings colon x-ray to you showing a rather extraordinary asymptomatic diverticulosis. Do you ask the surgeons to see him?
If it's simple diverticulosis, the answer is no. If it's diverticulitis, because of our change in attitude in recent years toward it, partly seeing it with a greater degree of frequency, then there's always a surgeon at my side.
Yes, and they're ready and eager, I'm sure. These Eastern patients will hold still. The Middle Western patients don't want to be operated on until they're ill. Dr. Castro, can you convince a patient he should have an operation for diverticulitis when he's only had an attack or two and isn't ill at the present time?
It just so happens I recently wrote an article about that. I'm not going to read it all, don't get scared.
Just happen to have a reprint.
But this reports 39 cases of diverticulitis that I operate on. But also included in it, there's 16 patients, which I call as follows. Follow-up on 16 reluctant patients with at least 2 attacks of diverticulitis. Out of these, 4 were operated on for diverticulitis elsewhere. This is a follow-up of longer than 12 years now. 3 of them were operated by myself during those 12 years. 1 died in an automobile accident. 5 are living with their disease, and they have reason why not to be operated on, such as cardiac or pulmonary disease, and their medical man definitely does not want to have them operated on. And 3 of these are living without any apparent disease at all. Now, all these 16 were told by myself that they should be operated on, they should have this segment of the colon removed. So that, I think, kind of answers the question of my feeling toward it.
Well, I think that's admirable. Dr. Davis, will you x-ray a patient who has an acute diverticulitis? Do you help advise the clinicians in this regard? What's your attitude?
Years ago, I would, but now, no. I find some excuse to send the patient back, and I'll usually get on the phone and tell him that, well, his colon is too hot, the patient's not able to hold it, but that's really not the reason. But that is an excuse to get that patient back to the doctor for another couple of weeks and have him to send him back after it's cooled off.
Reep?
Yes, Dr. Castro.
This is a new breed of rentgenologists, because I can remember back 20 years when the rentgenologist was telling us what to do.
I think my opening remarks were these, that years ago I would, but now no.
Would you consider a soluble contrast medium again, like powdered hypake solution? With caution, you can see more if it's acute. Once it gets well, you know, there isn't really much to see.
Well, a barium enema may be done in any of these ulcerative diseases with caution. And with caution means this. Use a warm solution, and ordinarily, if you're going to have your enema can about 3 feet above the table, then drop it to maybe 1.5 so that your injection pressure is lower. And then you do it cautiously. If this patient complains of a sudden onset of pain in the area where you see the diverticule, then quit. But I think it can be done with caution. Now, ordinarily, we like to put a pattern on these people, compress them to find out what the segment looks like, to find out whether they have any stenotic areas there. You don't palpate them vigorously, and neither do you use a compression paddle. So what I'm saying is that a barium enema may be done if it is done with caution.
Dr. Paulson, do you order these x-rays in the acute phase of diverticulitis? Are you wary?
No, I do not. And I even hesitate to order them in the acute phases now of ulcerative colitis. I've taken a leaf from Charlie Brown of your clinic, who writes that there have been some mishaps during the administration of barium enemas, during the giving of barium enemas for very acute ulcerative colitis. But we've learned that plain plates of the abdomen can give us a tremendous amount of information, not only in ulcerative colitis, but sometimes in diverticulitis. And we're now less aggressive, and we're willing to wait until the acute process assumes a quieter phase.
All right, Dr. Castro, can you comment on one stage in any case of diverticulitis? Just resect it and make an anastomosis, and that's it. One stage.
Well, let me first say that I think the safest procedure for a resection of any diseased part of the colon is a three-stage procedure: a colostomy, a resection of the segment, and the closure of the colostomy. I don't think that you get into as much trouble that way as you would by doing the primary resections or single-stage resections that we are doing more frequently all the time. I personally love to eradicate the disease of any individual in one fell swoop, but I think that we must play this by ear. We must see whether or not these people can stand a one-stage procedure, and if they can, well, that's perfectly all right. But if they're completely obstructed, I think a colostomy should be done. If they're extremely ill, again, I would do a colostomy and then resect later on when they recover. And at the same time, maybe close a colostomy. That would make it a two-stage procedure. But this is all calculated with thinking about the status of the patient at the time. I prefer, as I said, a single stage, and I've done single stages in massive infections of the sigmoid with bladder resections and so forth, and they've done quite well. As a matter of fact, I have not lost any sigmoidal vesical fistula because it was too radical a procedure. And out of the 5, not a one of them had a three-stage procedure. But this was just luck, I think. I would have, out of a drop of a hat, created a colostomy on these people if I thought that I could not get away with it. But again, let me say it, that the three-stage procedure is still, particularly in the hands of the inexperienced, the safest procedure that you can do in these people.
The surgeon in a community hospital opens the abdomen through a low midline incision and finds the pelvis completely obliterated by perforative disease of the sigmoid colon. You would prefer, and
I prefer to do a
that he would
colostomy on
make
that patient and drain the pelvis, yes.
I think it's a good policy in this day of everyone wanting to get everything done at once, is to never criticize anyone that does something that keeps the patient alive. And I think that what's done in one place and what's done in another may be a little different. But you can never criticize a surgeon for bypassing any kind of perforative disease and keeping the patient alive to go another day, either there or somewhere else for definitive treatment. I still think there's a place for it. We don't have to do it very often, but other people may see the need for it, and I'm all for it too, and I agree with you. I think it's a good thought. There are a few questions on diverticulitis here. Dr. Castro, suppose you operate on a patient with perforating sigmoid diverticulitis and you have to pull the sigmoid flexure up out of the pelvis. There's a perforation, there's a large abscess cavity that you rescue this sigmoid flexure from, pus dripping about and all. What do you do from this point on?
Again, I think that the procedure that I would prefer to do would be a resection. The rectum can be elevated very satisfactorily from the presacral space, and you have at least 4 more inches of bowel to work with. Usually the diverticular inflammatory reaction will not go beyond the rectal sigmoid anyway, unless there is an associated fistula into the vagina or bladder. And if it's just like you have mentioned with the pus in there, I do not hesitate to wash out the entire pelvis and do a primary anastomosis. And if I think that there is any reason that I should suspect my anastomosis, I will do a colostomy at that same time.
You haven't mentioned any drains. Most people put in some drains of some sort.
I think drainage of the abdomen is excellent in this type of a case. I know a lot of people do not use it, but I'm still a little old-fashioned, and I will leave a sump drain there to try to irrigate the area, sometimes with some antibiotic solution. I do wash the pelvis well, and I get rid of all the purulent material, and will leave behind some antibiotic in the liquid solution. So I don't aspirate that pelvis immediately, otherwise I'd be getting rid of the solution I've put in there. But the next day I will start with the aspiration and occasionally reinserting some of the antibiotic solution.
Don't you ever have the pelvis fill up with pus again after such an operation? This is something that I've seen.
Not fill up with pus. I don't like the way you say that.
With an intact anastomosis. Just resuppurate due to the
I have
colic
had,
disease.
yes, definitely, purulent secretion coming out through several weeks sometimes following the course of a drain, but no disruptions of the anastomosis.
Dr. Davis, did you want to say something?
Not about that in particular, but I wonder if I have the privilege of asking a question. How many of the surgeons before resection of a segment of colon do small bowel studies on these patients, screen the small bowel
2 minutes.
before operation for diverticulitis? As you probably know, Dr. Marshak and several others have reported definite reactions in the small bowel, most of the time the distal jejunum, adjacent to the loop involved with diverticulitis of the sigmoid. And in one of these cases, he reported there was an actual fistulous communication between the loop of sigmoid and the small bowel. And so this is to say that probably more of these patients are getting secondary small bowel changes that go unnoticed, or we just don't take the time to investigate.
I think if we took a vote in the audience among surgeons, we'd find that most people here have seen small bowel fistulizing to diverticulitis at some time or another, necessitating an additional resection. Dr. Castro, this is a hard question to answer, I think, but in what percentage of patients with ulcerative disease of the bowel is a perirectal fistula the presenting complaint?
I cannot give you the exact percentage as to how many. I know that some of them present themselves as anorectal pathology clinically as the first symptom that these patients have. And sometimes these lesions will be present for several years before the ulcerative pathology in the colon will establish itself enough for clinical diagnosis. The character of the ulceration should give you a lead as to what you're dealing with. If you're used to seeing fistula or abscesses or fissures in general, the run-of-the-mill type are somewhat different than the indolent type of ulcerations that we see in inflammatory disease of the colon. And the only thing I can say is that these lesions seem to be involved with more granulation tissue. A biopsy of them sometimes will show the presence of granulomas in the base of these ulcerations, and it's always wise to take a biopsy when you think that you're dealing with something more than a common ordinary fissure or fistula. But the exact percentage I could not tell you.
I think we might at this moment bring up preparation of the colon for disease, inflammatory disease surgery. Dr. Castro, do you prepare the colon with antibiotics for ulcerative colitis surgery?
No, I don't. I still use the standard sulfaphalidine. I do not consider that as an antibiotic.
Dr. Paulson?
When the patient gets to a point that surgery seems imminent, the patient's already taking antibiotics.
Dr. Castro, another question for you. If a child under puberty has ulcerative colitis and is under treatment, successfully rehabilitated but not growing, would you operate on such a child?
Yes, I would.
Does it make any difference whether it's boy or girl?
I don't think it makes much difference whether it's a boy or a girl. I think one of the things that we have to do is rehabilitate these children, and by rehabilitation we must include their normal or close to normal development of their sexual functions and growth of bones and whatnot.
What age do you think you could do colectomy and get some growth?
I think around 13 to 14 years old.
All right. Dr. Castro, one single item here that I think is important. Someone in the audience wants to know something about postoperative acute necrotizing colitis. Can you prevent that?
We'd like to prevent it, yes. And I think the only way in which we could have saved this particular individual would have been to have recognized this thing immediately and done an ileostomy and a colectomy on this particular patient. This was quite a frustrating type of a thing. She was an elderly lady, and she really was pouring buckets of fluids out of the rupture of the descending colon where the anastomosis was made, and later on through the colostomy and around the pericolostomy, loose tissue coming in from the abdomen. And we tried real hard to save this patient. It was impossible for us to do it. But I think the only way in which we could have done it would have been the earlier recognition of the disease and a more aggressive surgical approach.
Dr. Castro, another quick question, and we're getting into toxic megacolon. Do you always take out the colon, or is there something less you might do for toxic megacolon?
Cecostomy has been tried. Elevation of the transverse colon as a double barrel type of colostomy has been tried. But I think that these patients remain quite ill if the disease area of that colon is not removed. So I've always gone in with the idea of resecting the disease segment.
These questions are still directed to Dr. Castro for a moment. What do you do with the remaining rectal stump in a young patient with, number 1, transmural colitis or Crohn's disease, and 2, mucosal colitis? You connect them up, take them out, or what?
I have about 29, you're talking about young persons, I'm talking about a generality now of everybody. About 29 cases in which the rectum was saved, and this is what we have done since the early 60s when Dr. Aylett came out with his enormous number of ileorectal anastomoses with excellent results. And out of these, 1/3 of them have had their rectums removed, 2/3 were connected, and out of those 2/3, 1/3 of the total again was again operated on an ileostomy established. In other words, we're dealing with 11 out of the 29 patients I was telling you about. So it's just about 1/3 that we are able to have reestablishment of the continuity of the intestinal tract.
Dr. Paulson, you know and we know that patients with mucosal ulcerative colitis get well, and a good many of them remain reasonably well, literally forever. But have you ever known a patient with serious Crohn's disease to ever recover completely, never to have trouble again in your experience?
Well, I'd rather see 10 ulcerative colitis cases than 1 Crohn's disease, because there's always hope with ulcerative colitis. There's rarely any hope of eradicating the disease completely with Crohn's. In a follow-up from the Mount Sinai Hospital not too long ago, where resections had to be done for complicating granulomatous disease, I think the recurrence rate was somewhere between 40 and 54%. I think it was 40% when the inflammation migrated to the ileum following the surgical maneuver. And in about 54% of cases, it migrated to the rectum. It's dangerous to say never, and it's dangerous to say always when you're dealing with an inexact science and an art. And so I would say that ulcerative colitis, there's always hope that you can eradicate the disease, at least by surgical means. It becomes very extremely difficult and a very doubtful thing when you're dealing with Crohn's disease, surgery or otherwise.
Now, every year we get the same questions about terminal ileitis, which is Crohn's disease of the terminal ileum. And everyone always asks the same question. You operate on a patient, Dr. Castro, and you find an acute or subacute Crohn's disease of the terminal ileum. The ileum is all thick, hard, red. There's fibrin all over it. And there's local peritonitis, no perforation, and the patient has an acute illness suggesting appendicitis. A 3-day illness, say, fever and all. What do you do with this patient?
I just recently read an article where the wisest thing to do is to do an appendectomy and get out. But I have not followed this course. I've done a resection with an iliotransverse anastomosis.
Don't you believe there is some type of acute terminal ileitis that's self-limited, and if you just don't do anything, it'll get better?
I believe so, yes.
What about side-to-side iliotransverse colostomy? As far as I can see, this is being done all over the country. Eisenhower's operation.
Mm-hmm. I think that if a patient is acutely ill and you believe that they will not withstand a resection, that is perhaps, well, not side-to-side, but an end-to-side
exclusion operation.
Exclusion type of an operation. But I still believe that if the area is diseased, it should be removed.
Do you have intent to remove that later, just to make a final point?
You mean if I've done a...
exclusion.
No, in the ones that I have done exclusion, I have not removed the part later on.
Now, Dr. Paulson, what would you like your surgeon to do for a case of acute regional enteritis with a 2 or 3 day history? Do you take a stand on that?
Well, if it's just a 2 or 3 day history, it's quite possible that if they waited, again, there might be some restitution toward normality. It's well known that these acute Crohn's disease problems are usually referred to the ileum or ileocecal region, for which appendices have been erroneously removed, that in some instances there is reportage of reversion to normality. And since we are not dealing with an acute appendicitis here, it strikes me that it would be safe to wait some days in the hope that nature would restore the situation to normality. How often that occurs, I don't know. I know that Beryl Crone writes about that at times, but as I say, personally, we get to see the cases when they are no longer acute, when they're active, chronic, persisting, with complication.
We have time for one more question. Let us say that colectomy has been carried out for mucosal ulcerative colitis, which we admit is a pre-malignant disease, and the rectum is spared, and it's good enough to hook up to the ileum, avoiding ileostomy on a permanent basis. Year after year, on proctoscopic examination, do you feel that it's worthwhile to biopsy the rectal mucosa to detect changes toward malignancy? Dr. Paulson.
I must say that if one were to look into the bowel of all these people with chronic inflammatory disease, whether it's ulcerative colitis or so-called Crohn's disease, in which the rectum is supposed not to be involved most of the time, one would be surprised to note how frequently there are changes. They may be minor, they may not be striking, but changes will always be seen, or nearly always be seen. And if there's any doubt about it, biopsies, I rarely do a sigmoidoscopy without a biopsy, even on so-called normals, because once in a while the pathologist does surprise me. Even where the rectum and sigmoid endoscopically looks rather good, it's surprising that the pathologist indicates that there's some low-grade activity present on the biopsy. In ileosigmoidostomies for epithelial cryptogenic, or what's known as the old-fashioned ulcerative colitis, complete relief or complete cessation or complete absence of even overt activity in the rectum and in the lower sigmoid, odd as it may seem, is not common. It's surprising how many people are perfectly asymptomatic, manifest no objective indices of persisting disease, who symptomatically are well, but the mere introduction of the sigmoidoscope will indicate mild persistent changes, sufficiently mild to give them no symptoms, but complete healing has not taken place, and that can usually be confirmed by histologic examination of a biopsy specimen. So that complete subjective as well as objective cures in any of these diseases are not as frequent as we have been led to believe were we to do the sigmoidoscopies and the biopsies with regularity.
Dr. Castro, do you biopsy for this to follow these patients, yes or no? Our time's up.
Yes, I like to biopsy any area that does not look like the surrounding area.
All right.
And this concludes another issue of Audio Digest Surgery, produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. Coming up, a program of highlights from the Ogden Surgical Society's 25th annual meeting.